thank you very much. Of course, welcome. Good morning. Beautiful day. What a view here. So what I would like to do is, there's many aspects of APRV really, and one aspect, although not essential, in other words, the patient does not have to breathe to use APRV. But one key aspect is spontaneous breathing. And I think this is an important topic because, in my view, there's a lot of misunderstanding about spontaneous breathing. I'd also like to add that I certainly would have no issue if anyone has a question while I'm speaking. So if there's something I say that is not clear or something, feel free to just stop me, and happy to discuss that. So let's talk about spontaneous breathing. I think that first, it's important from the mechanical ventilation perspective to really try to understand what the essence of spontaneous breathing is, because we have lots of modes where the patient triggers and the machine reacts. And in my view, that is not a spontaneous breath. A spontaneous breath means essentially that we are not altering the flow time course of the breath. And if you look at pressure control, the breath is decelerating, triangular shaped. The airway pressure is going above baseline. So we have a baseline pressure, and then in order to move gas, we have to add pressure to drive the gas in. Volume ventilation, very similarly, it's a square flow pattern. Pressure builds up very more gradually, and you can see that, again, the pressure is going above the baseline pressure. Now, of course, when we're breathing, we don't change the pressure in the room. What we do is change the pressure relative to the room by decreasing the pressure in our chest. And this allows flow because we now have a pressure differential, because there's no flow without a pressure differential. And of course, our more normal breath looks like this. It's more sinusoidal shaped. And if you look, this is on CPAP, of course, the pressure does not change. So the only way to have a pressure differential is to have some difference below the set pressure. So of course, atmospheric pressure would be 0, but in this case, it's 10 or 15 or whatever the pressure may be. So that's really important. And again, if you look at, let's just use pressure support as an example, the patient just merely needs to trigger. And now the trigger is essentially telling the machine how to react. It has no proportionality, it has no concern for the time course of that effort. And of course, what we want to do is, as we inflate our lungs, of course, and our lungs get bigger, we naturally decay our ability to pull more air into the lung. You can see here, the power is going to go substantially down. And so essentially, the sinusoidal breath is essentially a mirror image of what you're going to be doing with your muscular effort. And the flow is not outpacing the patient. And again, for me, I would just say the essence is that the time course of flow is controlled by the patient. It's not just initiated by the patient. The machine has to be controlled by the patient, not the other way around. So in essence, a CPAP breath essentially mimics that. Now, in some variations of APRV, we frequently have the ability to add pressure support. And I would just tell you, in my view, that's not a good idea. And for two reasons. One, it will completely convert the breath to a decelerating assisted breath. And here you're back to pushing air into the lung, especially in a supine patient. You're going to have more non-dependent ventilation. If the patient pulls air into their lung, they're going to draw it in the dependent parts of their lung. And this is what we want. Ultimately, what we want is, we want to use all of the lung. We don't want to just half the lung. We want to use the full area of the lung, not only for gas exchange, but probably to perhaps improve how the strain in the lung tissue develops, because the area that you distribute stress, which is pressure and volume in this case, it needs to go over a big area. So that defeats the purpose of spontaneous breathing, in my view, if you add pressure support. And perhaps more dangerous would be the idea that what we want to do is set a top pressure. We don't want to exceed that pressure. So whenever you set a P high, which is a CPAP level, you really don't want to pressure above that, because what's going on is that as the lung volume increases, the patient's diaphragm becomes in a position where they cannot generate any volume change. So if you happen to set it too high, you have that natural sort of safety, if you will. Your lungs can't get any bigger. The chest wall will stop it. The diaphragms will lose power. So this built-in safety feature will be overridden if you have a trigger that results in a pressurization of the system. So those are the two reasons why we never use pressure support. And in my view, those are two separate modes. They should not be intermingled. Unfortunately, some commercial products have this. And to some extent, this is what happens. This is actually one of my patients that was undergoing a 4-hour procedure, abdominal procedure for trauma, and had some problems towards the end of the procedure, could not complete the procedure, went to CAT scan, and you can see the lung is really healthy. Looks pretty healthy on CAT scan, except the entire dependent part of the lung is collapsed. And of course, under anesthesia, not spontaneously breathing, we're going to be pushing air into a passive respiratory system. We're going to have preferential ventilation here, and we'd rather have the patient actually pushing away their abdominal contents because there's a significant effect on lung volume. Now, Eckert, sorry, these are very old pictures. This is the original, probably, image of EIT. This is from a colleague of mine from Tokyo Women's, and was starting to use APRV, and one of the questions we were always talking about is, can we see what happens when people start breathing? Of course, this is on assist control. You see P10, and I know we haven't probably gone over EIT in great detail, but in this sort of color scheme, red is essentially more air. The signal is for more air. So you can see, if you look, the maximal, let's just say the maximal point of air is relatively in the upper part of the thorax. See, this is where the heart would be. But after transitioning to APRV, you can see that the distribution is changing a little bit. And after 120 minutes, you see the very red spot has moved more into the dependent regions, suggesting we're improving the ventilation in those dependent regions. Now, if you look at the airway pressure, P high is 26, which would be equivalent to the plateau pressure here is 30. We use, of course, no PEEP, but we're controlling the time low, and we have a prolonged CPAP phase of 8 seconds. So, in my mind, our patients absolutely need to breathe. There's no way around it. If you ever want to extubate your patient, you have no choice. If the patient never resumes the ability to breathe independently, you will remain on the ventilator. So in my mind, it's not whether they should or shouldn't. It's really when should they do it, and is it better to do it early or late? And I think that's not an easy question to answer, because it depends on the patient. And so we know that many patients are dyspneic on mechanical ventilation. This is actually some people say this should be another vital sign, that we should actually look more carefully at this. And certainly many reasons for it. The endotracheal tube is really, we have patients that have so much injuries and would have lots of reasons for pain. The pain, is not their issue. We can take care of their pain. The discomfort of the endotracheal tube is something that no one likes. So the patient may have absolutely no pain despite having traumatic amputation or open abdomen, but the endotracheal tube is still problematic. And of course, the way we set the ventilator is also important. And we are dictating to the patient essentially how to breathe with our settings, because we have, this is what your volume should be, this is what your rate should be, this is what your flow rate should be. So we're telling the patient, you have to fit into our idea of breathing. And of course, there's a potential to make the patient quite dyspneic. It's actually pretty common, and the most common reason is air hunger, or not enough flow, because human breathing is not really monotonous or monotonal. It's really quite variable. And the healthier you are, the more variability you have. And so if the patient's metabolic rate changes, let's say at 2 in the morning, while we're all asleep at home, the patient becomes septic, has a fever, their metabolic load doubles. Even if they looked good before you went home, they may have a completely different desire to breathe at that point. So if we have zero flexibility in our settings, then the patient cannot adjust their breathing to our settings. And of course, typically, at least in the United States, what would happen is if the patient disagrees with our ventilator settings, we make sure they agree by sedating them or paralyzing them. So now you must accept what we set. So I think this is just perhaps a different concept about that. If you look at the surveys, most patients that have dyspnea are on assist control, and it tends to be volume assist control. And volume is really fixing the flow. And of course, we know when patients have air hunger, they will essentially create a vacuum in the system. And that's not a good thing for their lungs. And of course, they can develop very high pleural pressure. Perhaps PEEP is also important. I think that, we were talking about this last night. Of course, there's a PEEP FiO2 scale, but that's not really taking into account what we're really trying to do with PEEP. What we really want to do with PEEP is maintain end expiratory lung volume or as a surrogate to FRC, because we cannot breathe well without a baseline lung volume. We need that lung volume. We're not designed to have empty lungs and then try to open it up dynamically with tidal breathing. So this is really the key thing, but we tend, as clinicians, set it to, well, what's the PO2? And that may have nothing to do with restoration of adequate lung volume for the patient to begin their spontaneous breath. And to some extent, what we're doing with APRV, that's our goal. We want the patient to have adequate lung volume, and when you do that, we find they need no further assistance. We don't need pressure support. If you set the patient at the right lung volume, they will be able to breathe without any need for additional pressure at all. And of course, that would preserve a more natural breath and the inspiratory flow rate. Now here's a patient. You can see how much effort this patient is making. And you can see even the machine is registering a negative mean airway pressure. Now, of course, this is at the airway, so it's probably even worse in the lung. And this patient is flow starved. And here's another patient. This is a patient on low tidal volume. This patient was on low tidal volume strategy with autoflow or PRVC, which is actually algorithmically going to allow the patient to get more air. And so what happened was the physician wanted a certain tidal volume to do low tidal volume, but the patient wanted twice that much. So they were moving more air, lowering the pressure. So in order for them not to have this tidal volume that was 800 cc's instead of 400 cc's, they switched to volume ventilation. And now you're able to see what's going on in volume ventilation. So the patient's making an effort, pulling the PEEP level down, is pulling throughout this breath, essentially rounding the airway profile, and you can see just massive amount of effort. So in my view, this is not good spontaneous breathing, because this is going to have high effort and high transpulmonary pressure, very likely. I'll just show you a patient here. This is on low tidal volume strategy. Now, normally the thoracic cavity of an adult around age 18, it becomes very rigid, babies, soft chest. So it's very difficult for an adult to pull their sternum inward when they're breathing, when they're making an inspiratory effort. If your sternum is caving inward, that takes a lot of effort. You have either flow limitation or your lung is collapsed and not allowing the thoracic cavity to expand. But this is high effort, and the patient will not be comfortable. And of course, you can sedate them, but this type of breathing pattern may not really respond unless you paralyze the patient. Because of course, this is a brainstem effort, not a cortical effort. So of course, you can remove both hemispheres, the patient will still breathe and have distress. And this is why we can't really do away with this. This is what I was talking about. You'll see that the patient, if you use PRVC or autoflow, the airway pressure can become quite low. The patient's actually on CPAP here. You can see they're pulling the airway pressure down because the algorithm if the patient moves a certain volume, then the machine is not going to add additional pressure. And so you can mistakenly look at this and say the patient is not really using a lot of support. And frequently the tidal volumes are higher than what you want to set. A good example of that is the Oscar trial. If you look at the Oscar trial, they wanted to do 6 mLs per kg. They used PRVC, excuse me, and they actually ended up close to 10 mLs per kg, because what you set and what the patient is going to get is completely different. So if you really want to control tidal volume, you'll have to fix the flow. Oh, thank you. Fix the flow, and of course if you fix the flow, the patient may develop air hunger, and then you have to decide what to do next. And in fact, we'll see this patient, you see this patient's tidal volumes. I'm sorry, it's a little bit blurry, but this is supposed to be 400 cc's. See how much effort the patient is making, and of course the machine will lower the pressure. And then the patient might get tired, and the pressure will go back up again to maintain the fixed tidal volume. And this frequently happens. So of course that leads me to this study. And in this study, they found that if you use neuromuscular blocking agents early, you may actually improve the outcome. And I think this is an important point. But the point I would like to make is that, well, number one, this was done with fixed flow volume ventilation. It was also done using low tidal volume strategy and what I would say is a non-physiologic PEEP FiO2 scale. So I would strongly suspect that these patients were, compared to APRV, had a much lower lung volume, because we know an APRV or lung volume is much bigger. So the lower your lung volume, the more curved your diaphragm and the more effort you can really make. And so perhaps in this setting, I would probably say this is a good idea to perhaps paralyze them. The other thing I would like to add is that these patients had clinical ARDS. So by PF ratio, they had ARDS. And we know those patients, if you cannot stabilize the lung, you're going to have lots of effort with not much improvement. So if your lung volume cannot improve with our settings, you're still going to have a very small lung, a consolidated lung, a collapsed lung, and every time you make an effort and the thorax wants to expand the lung, it's going to pull the chest back down again. It's going to be very, very hard for the patient to breathe. Now this is a little bit different than what we do, and I'll show you that what we try to do is actually not wait for them to develop lung injury or collapse. Our goal is that they have normal lung volume throughout their hospitalization. And of course we use APRV for that because we think it supports the lung better, it improves lung volume, and we attempt to maintain a 50% minute ventilation that's spontaneous within the first 24 hours. So no matter how severely injured the patient is, we try to at least have 50% of their spontaneous breathing to be spontaneous. And the reason for that is there's more and more evidence that what we also do during mechanical ventilation is we may impact the diaphragm negatively. And collectively, this is called ventilator-induced diaphragm dysfunction. And if you think about it for a moment, even while we were all in utero, our diaphragm was contracting. And hopefully your diaphragm will contract for many, many more years to come. And that has never stopped. Your diaphragm, unless you have surgery or someone paralyzes you, your diaphragm has contracted ever since then. Because this is a vital muscle for life. You stop the diaphragm, you die. You stop the heart, you die. Those two muscles are vital for life. So they're not really designed to say, okay, just take a break for a week or a couple of days. And when you do that within a period of time, in animals anywhere from 12 to 24 hours, the diaphragm physically changes and mechanically changes. It cannot develop the same effort and force. And if you allow spontaneous breathing, roughly 50%, you can mitigate, not all, but some of these effects. And this is why we target 50% of our minute ventilation. Because some people believe, I don't know that we've proven this, but there is some belief that what you do to the patient in the first couple of days, even if you get away with it, it doesn't mean you're going to get away with it later. So in my view, a lot of what we do in the beginning will potentially come back and bother us. So if we change the diaphragm, make it weaker, make it less sensitive to the electrical current, then we may be setting the patient up for a more prolonged weaning phase. And the longer the weaning phase, the more likely they are to have some complication. And that's why I think it's important if we can address this. And of course, this is just the difference between 2 hours versus 18 to 69 hours. You can see just physically smaller. There's a lot of molecular changes that's occurring, but this occurs in the slow and fast muscle fibers. And of course, we need both, fast for coughing and doing things like that. And of course, when we remove the tube from our patients, we want them to breathe deep and cough, breathe deep and cough. We keep saying that to our patient, but if we don't have them have a strong diaphragm and so on, they may not be able to do all that we want. So I think this is an important consideration. This is a review article if anyone's interested. It does reference, I think, rather well all the animal data, again, multiple species going back perhaps 20 years, discussing this concept. But this was human, many more studies now showing human diaphragm changes. So I think that's important, and this is what happens when you spontaneously breathe. A little bit of spontaneous breathing, again, does not improve this 100%, but seems, at least in animal data, to lessen the impact of completely making the diaphragm passive. And as I said, it only takes 12 to 24 hours of passive ventilation. Now certainly you can, there are of course times that you have no choice. Your patient goes to the operating room and you need paralysis. That's the case. But even in the operating theater, more and more people are thinking about letting the patient breathe a little bit more. Certainly, perhaps now let people breathe more, even in the operating room than in previous years. On the flip side, we do have some animal data that says that if you let them breathe, even in acute lung injury, you will improve inflammatory response and lung injury. Again, these are animal studies, and I think what's important, these were both in lung injury models, but I want to stress to you that our approach really is looking at the patient and looking at their lungs, and the majority of our patients will have normal lungs, even though they have severe trauma or soft tissue infections and sepsis. They have normal lungs usually in the first 24, 30 hours. And we know from the epidemiologic data that most patients develop lung injury after 30 hours of mechanical ventilation. So it's something that happens during mechanical ventilation. So the bulk of the patients develop ARDS in the hospital and 30 hours after ventilation. Of course, there's going to be a patient that comes in with a flu and a viral infection that has horrible lungs when they first come in, but the bulk come in later. And this leads me to this book, which I've been struggling with for probably more than 10 years. It is quite a struggle. But there's a lot of information here, and just to give you an idea, a lot of times we like to reduce spontaneous breathing to, are they breathing in, breathing out, and that's it. And we don't really think about the complexity of breathing. It's really quite complex. Would never even begin to say I have a complete understanding. My partial understanding is that there's been a lot of research done in this area, and we're still learning. So 1,400 plus pages, 5,000 references, more than 100 years of research, I don't know how many authors, but we know this is a very, very complicated system. And there's not just one, of course, breathing center. There's multiple centers that control breathing, and they all have their own little individual control of breathing. And perhaps the one I'm going to focus on here is right in this area. And this is really I think the genius of the brainstem is that it's looking very carefully at a lot of information coming back. Of course, the respiratory system, the muscles, do not independently do whatever they want. The diaphragm doesn't just contract, or the rib cage, it doesn't just, I'm going to breathe now. It's controlled by the brainstem. And the brain is controlling that based on the information it receives. It looks at stretch receptors, it looks at the chest wall, it looks at the diaphragm, it looks at blood gases, it looks at many different things and determines what is the appropriate breathing effort that the muscle should do. And another important aspect here is this is a switch back and forth. And as soon as you start breathing, the patient will automatically, or any of us, will automatically inhibit inspiration. So once you initiate an inspiratory effort, there's a automatic suppression of inspiration, and as your lungs get bigger and bigger, there's an automatic activation of expiration. Now normally we don't delve into those kinds of lung volumes because inspiration is active, and then we just let go. Expiration is passive. We don't have to actively exhale. But certainly if your lung volume got big enough, you would actively exhale and you would completely suppress inspiratory drive. And again, I'll skip over this because it's just a lot more detail. Now this patient, I promise you, will have a hard time spontaneously breathing. So this patient's lungs are relatively white. There's, we know white is not air. Air is nice and black. So there's less air in this patient's lung, whether it's collapse or consolidation or edema or some kind of combination. It's going to be very difficult for this patient's diaphragm to create enough force and have good aeration. And the lung is not going to fill the space that the chest wants to create. So therefore, this patient is going to be distressed. So perhaps spontaneous breathing is not for this patient. But as I said, if you start the patient with the right lung volume and you maintain that lung volume, you may find that you never have a problem like this. And of course, later on, we'll show you some data that suggests this is the case. But a lot of this is maintaining their lung volume. And we know that if you increase their end expiratory lung volume, they're going to have less dyspnea. And of course, we are very good at decreasing people's lung volumes. We lay them flat, we sedate them, we paralyze them. If they try to get up, we tie their hands down. So we make sure they have no chance. So we do all of these things. And it could be just as simple as maintaining their lung volume. Now, I just want to show you a patient. This is a patient of mine. And this patient is, the pressure is 35 centimeters. 35 centimeters. And if you look, this is a spontaneous breath here. The patient's tidal volumes are 800, 900 cc's. Now, I promise you, and we actually have a ventilator, right? So if there's any volunteers that want to be placed on 35, just raise your hand. But if I put anyone here, or even myself, on 35 centimeters of pressure, your diaphragm would be like this, be flipped, and you would not be able to move any volume at all. You would be on the flat part of the pressure volume curve. So I can tell you this patient is not on that flat part of the pressure volume curve. There's no way the patient can breathe comfortably with that tidal volume being on the flat part. Of course, we don't like being on the low part of the pressure volume curve either, because it's very difficult for us to breathe. So I know this patient's on the steep part of the pressure volume curve because they're comfortably breathing. Now this patient is more than 200 kilograms. He has a gastric bypass that went very wrong, and he has an open abdomen, and he's very edematous, and his chest wall is an abdomen or squashing his lungs. And 35 centimeters is just restoring his lung volume. And this is really important. It's lung volume. In my view, we obsess about pressure, but it's really lung volume. And in fact, the lung works better at a right lung volume, and so does the heart. The heart and lung actually work better at the right lung volume. The heart does not like low lung volume. It doesn't like high lung volume. It likes it right in the middle. That's where we're designed to breathe and sustain our circulation, in that region. And so if we have to apply pressure to restore lung volume, it just happens to be 35 because of the patient's chest wall and abdomen. It's just what we need to do. If you lower this patient's pressure, if you say, oh, no, we can't have 35, we must have 25 or something, and the lung shrinks, this patient is going to be very dyspneic. So it's important to consider that. And of course, this is why I think when I was much younger, we used to use a 3-liter syringe, and we used to paralyze the patient and try to come up with their compliance curves. And we thought we had paper, and we'd write, we used calculators, and we thought we were very smart. In my view, that it doesn't make any sense at all. That you're changing the patient just by doing the procedure, and you can determine, we just simply cannot breathe at the extremes of lung volume. We cannot breathe up here and here, because of course it's flat. And work is going to be the change, force times distance, or in the lung, pressure and the volume moved. Here, all pressure change, no volume. All pressure change, no volume. So lots of work with no benefit. We must breathe on this part of the pressure line curve. Now, if you go back to the 1980s, you'll find a lot of data on CPAP. And one of the things that's important is your ability to generate force progressively goes down as you increase CPAP, but also your lung volume goes up. So as your lung volume goes up, your desire to breathe goes down, inspiratory drive, and at the same time you're mechanically somewhat limited to that. And I think very interestingly, you have a more passive inflation of your lung, not an active one. But in this case, what happens is we flip everything around. Inspiration becomes passive and expiration becomes active. So if you put someone on CPAP and you achieve the right lung volume, what you'll see is they will not make an inspiratory effort. They'll use their abdominal muscles to control their lung volume. And this in the old literature is collectively called defending your lung volume. And if you watch this little video here, you'll see as your lung volume gets bigger, CPAP level goes up. At some point you have to squeeze the air back out, and then if you relax your stomach, your lung will passively fill. And this is called defending your lung volume. And you can titrate the CPAP level and see people switch from inspiratory, active inspiration to active exhalation. Of course, if you can keep going, they'll look like they want to have a baby or bear down. Of course, that's a little bit too much expiratory work. You don't want that. And so ultimately what we want is someone who's comfortably breathing on CPAP. Because as Penny Andrews mentioned today, really APRV is a variant of CPAP. The only reason we decide to take a little eraser and erase a little bit of the blue area to create a release is to offload some of the metabolic work of breathing. Because we have elastic work, resistive work, and of course metabolic work. So that removal of carbon dioxide allows the patient's metabolic load to be manageable from spontaneous breathing. And I'll just speed this up here. And ultimately what we want to do is mimic, this is on 0. So this is spontaneous breathing without any pressure. And you can see it looks essentially the same. And we look at their work of breathing. We use the Rapid Child Breathing Index. We don't use it just for extubation. We look at it to have some idea of their work of breathing. So expiratory muscle aids inspiration. You can use CPAP to optimize the length of the diaphragm. Again, if used too much, it'll be the other way. And certainly in COPD, it has a significant effect on unloading the inspiratory muscles, especially inspiratory muscle fatigue. It decreases the inspiratory resistance because the airways are actually bigger. The higher your lung volume, the bigger your airways are and the more stinted they are for airflow. And to some extent, I mentioned that there's going to be an assisted portion of the breath. In other words, it has nothing to do with muscular activity. And if you look at tidal volume up here, you look at flow, here's the pressure in the diaphragm, here's the diaphragm, here's the EMG of the diaphragm. So before we actually have an electrical signal, the diaphragm is actually contracting. You have tidal volume and flow. And again, this is from the expiratory assistance, resulting in an inspiratory effort. Now this is one paper, but there's many papers, and actually, I'll tell you my favorite paper. My favorite paper, some very smart researchers many years ago decided to take a dog. I think it was a big dog, I want to say a Great Dane, and the study was to lift the dog up on their hind legs. And of course, if you do that, the lung volume of the dog becomes quite large. And the dog started using their expiratory muscles to squeeze the air out and relax and fill their lung. So if you have a big dog at home, you might want to lift their legs up and see if they're using their abdomen to breathe. But this results in essentially a 30 to 50% inspiratory effort that's assisted. And maybe the best thing to do, okay, so maybe the best thing to do is actually look at patients on EPRV. So these patients are on EPRV, and we use the way they breathe, which muscles, because I'm trying to understand what their brainstem is thinking. Which muscles does it want to control? So if you watch this patient is going to defend their lung volume. Now they're going to be using their, you can see they're squeezing here. So they're on that CPAP level and they're squeezing down. You notice their upper chest is quite quiet. And maybe this patient isn't the best to show this, but typically once they squeeze and then they relax, that moment that they relax, they get a little boost because the system is trying to repressurize. So let's take another look at a patient. This is, let's take his gown off. Sorry. See how easy I did that? So if you watch here, so you see the squeezing, but watch the chest now. When he's finished squeezing, it'll just bounce a little bit. And this is why they can breathe actually at relatively low rates. They're comfortable. We don't have to take away their breathing efforts and control their ventilation. It's much easier to see in person, so I usually show a couple of videos just in case. But again, you can see he's going to squeeze with his belly. This is active exhalation. And then you can see, I think, the bounce that he has when he lets go, when he relaxes. And so this is, for us, a way to adjust the pressure. Now, if I continue to raise the CPAP level, at some point you're going to see continuous exhalation. They're not going to go like this. They're not going to squeeze and relax, squeeze and relax. They're going to go like this and hold, hold, hold. You're going to be pushing against that the whole time. And of course that suggests that you may have too much. I think you've probably seen, hopefully you were able to see what I was pointing out. Is that? Okay, so I won't torture you with more videos then. Okay, one more. I think this patient is good for the chest bounce. So you can see very subtly the squeeze and then let go. Very subtle chest bounce. Maybe something. Oops. Let me see if this is the patient. No. I think this might be the patient here. Okay, so let's look at this patient. Now this patient, you can see he's doing a little bit more effort than probably what we like. It's not the ideal patient, but so we don't want to see them actively sustaining an exhalation. We just want a little squeeze and relax, squeeze and relax. That's really what you want. And again, if you were to look at this on a pressure volume curve, if your baseline lung volume is quite low, of course you're going to have more effort to come above this. And of course this is where we would use something like pressure support or something dynamic to amplify tidal volume without any regard for lung volume, where you're starting your breath. Which again is very important because we all start our breath here on this steep part. We don't start it down here. But so this makes inspiration active, and then of course you let go and it's passive. But because in APRV your lung volume is higher on the pressure volume curve, what you're doing here is actually squeezing the air down. So you're squeezing the air out of your lung with active exhalation, relaxing, and it bounces back up. And you keep doing that again and again. So again, it can really unload their inspiratory effort. So I'm going to talk a little bit about hemodynamics, but I just want to see if there's any questions here. Yes, of course.
You talked about the diaphragm earlier.
Yes.
Basically, to me, what you're saying is that you're not really using the diaphragm in this type of breathing. So what do you think that does for how they will be able to resume their normal pattern of breathing after?
Yes, that's a good question. Thank you, because I think that's very important. So when I said that there's an assistance of their breath, they still have this is just occurring before the diaphragm contracts. But what they will do is continue through that. So it's really just a little bit of a push. So they don't have to generate a huge negative force, I guess is what I'm saying. And I have a colleague in the UK that's been doing more transpulmonary pressure measurements. We're going to be also showing some transpulmonary data. But the pressure in the stomach area, the gastric pressure, will go up. And as this pressure drops, when they squeeze, their gastric pressure goes up. They let go, the gastric pressure drops, and then you get this. So we believe there's still diaphragmatic contractility. The older studies do suggest that that little boost is still followed. It occurs before the electrical contraction, but then the electrical contraction of the diaphragm continues and continues the breath. So I think that's a very good question, but you will see the patient will still breathe, and typically you'll see a quiet chest, and you will still see their belly expand as their diaphragm comes down, because when their diaphragm comes down, the belly will go up as the chest goes up. So we want their diaphragm to be useful. Any other questions? Okay. Now this is I think an important paper because it helps us understand a little bit about lung stress and strain, but I'm not going to be talking about that. I think later I will address this paper, but I just wanted to show this from the perspective of what happens when we apply a total pressure in the system that's static versus dynamic. So if we inflate the lung to a certain, in this case, apply enough energy to change the lung 2.5 times FRC, but we do it by inflating the lung, deflating the lung, inflating the lung, or just by inflating it and holding it, is there a difference in their hemodynamics? Because of course many people would say, you're holding the pressure for such a long time, that must affect hemodynamics. And this is not perhaps a very easy slide to see, but this is the dynamic here, which is 0 peak, but all tidal volume to make that lung quite big. And this is mostly peak or mostly static. And if you look at the beginning of the experiment, this is the initial blood pressure. The mean arterial pressure is 84. Here it's 71, so yes, a little bit lower. But over time, what you'll see is the mean pressure here is 49, and this is actually probably the same number, unchanged. So the hemodynamics are actually better when you sustain this, and there may be multiple reasons why. I think part of this is also whether the chest wall improves its size to accommodate more of the organs that live in there, including the heart. And of course, when we use static versus dynamic inflation, there's a big difference in lung injury patterns. We also know that, and this is based on old data, but this is a slightly newer study in the sense that it's looking at echocardiogram. But if you allow the lung to collapse, you're increasing the right ventricular afterload. Because normally, of course, the right heart is not really a pump, because the pulmonary circuit is so massive that the blood is actually, it's like it's falling downhill. It doesn't need to squeeze. But that's because of the massive surface area of the capillary bed. But now you start collapsing the lung, you may actually reduce the capillary bed, and you're going to actually increase the pulmonary vascular resistance. So pulmonary vascular resistance is not linear, it's bimodal. So at very low lung volumes, it's quite high. It goes way, way down at FRC, and then starts to go back up at total lung capacity. So again, suggesting the importance of knowing lung volume, not the pressure. So as you can imagine, it would be hard for most people to consider increase the airway pressure because their hemodynamics will get better. Of course, most of the time we say lower the airway pressure if you want their blood pressure to be better. But if you have a lot of lung collapse, you're going to actually make the right heart perform better, get the blood through the lung, over to the left ventricle, and much better. And if you look here, this is recruited, this is after lung injury. Then you de-recruit, you see the right ventricle gets very big, the left ventricular cavity gets very small. And then you re-recruit, and of course, it improves again. And when you add pressure to the lung, and you recruit the lung the systemic lactate is improved, suggesting perfusion is better. So the difference here is that the airway pressure is actually higher here, increased, not decreased. So again, just remember, it is not bimodal, linear, it's bimodal. It doesn't mean more pressure, worse hemodynamics. And this is exactly what happens in terms of the pulmonary vascular resistance. You can see residual volume, total lung capacity. You can break this down into alveolar and extra-alveolar. Of course, extra-alveolar vessels, as your lung volume gets bigger, they get tethered open. Capillary beds at some point will collapse when you get too high. But ideally, we want to be on that part of the pressure point curve. We don't want to be below or too high. This is where we like to operate. This is taken from one of our APRV studies, and this is a what we call a septic gut ischemia model. And here is baseline, and we're going to go to 48 hours. Oops. 48 hours. And let's look at mean arterial pressure. This is also a sham group, which is considered a control group. These animals here are very septic. They have 3 enteric organisms in their bloodstream. They have leukocytosis, hyperlactemia. They're on noradrenaline and receive roughly 57 liters of fluid in 48 hours. And here is the blood pressure. You can see the low tidal volume in the beginning, baseline a little bit higher. But as you continue on, you see that we are mainly in the 80s and 70s here in the APRV group, and we come down into the 50s and 40s in the low tidal volume group. And if you come down to the norepinephrine dose, you can see that single-digit norepinephrine. Here you're into double-digit norepinephrine. So more norepinephrine for a lower mean arterial pressure in low tidal volume versus APRV in terms of hemodynamics. And again, it's not, as in my view, as simple as what's the pressure in the lung. Now I just have to tell you a quick story. Many years ago when I was younger, I spent some time with Luciano Gattinoni. I went to Monza. This is before he became very famous. He was in a smaller area. And at the time they just finished the ECOR trial. And I was a fellow where we were repeating the ECOR trial in the United States. And so I got to know the Italians that were actually with us. And so I went to visit him in Monza. And of course, at the time, they were just CAT scanning everybody. As soon as they come in from another hospital, they would go straight to the CAT scanner. Of course, for me, it was a little bit of a shock because we didn't even put a stethoscope on the patient. They went straight to the CAT scanner. Didn't examine the patient, straight to the CAT scanner. So he was looking at a CAT scan with me and was asking me, what do you see here? And I of course said, this lung looks like this, saying all kinds of stuff. And he said, no, what else do you see? And of course, I didn't know what he wanted to know. So eventually he told me. Now he published this paper in the New England Journal. This is from the New England Journal, I think it's 2004, about 2006, thank you, recruitment. Now in the article he doesn't mention this, and that's why I'm bringing up this sort of personal story here. But he told me, look at the heart. And of course they would recruit the patient under CAT scan. And he said, look at the heart. In a patient that's not recruitable, their heart gets small. In a patient that's recruitable, the heart doesn't change size very much. And of course his point was that if you collapse the lung, the chest wall will shrink to a point. But when you apply energy to the chest, it will re-expand. But if let's say the lung is consolidated, so the volume of the lung has not changed, it's just been replaced with air, and so the patient is not recruitable. You apply pressure, the chest can't go out, things may get squeezed that are very soft, and maybe the heart. So again, I think the chest wall is also an important part of hemodynamics. It's of course important for lung volume as well, and how much pressure we need and what the transpulmonary pressure is, but I think there's definitely an element of hemodynamics. So anyway, small personal story. Unfortunately, I wish he would have mentioned that in this article. He does not mention it, but just as an aside from that, I think we're going to stop here and see if there's any questions. Yes. Yes, sir.
Regarding that patient with the FiO2 of 35 and the pressure of 35, what would be your next step in dealing with that patient?
Also a very good question. Perhaps in the next discussion, we're going to be talking about weaning. And I would have to say the philosophy, as you can imagine, the philosophy of APRP is all flipped around, and so is weaning. So at least we're consistent there. So what we do is incorporate a few other key aspects. And one of those aspects is we try not to reduce pressure. Not initially, anyway. We actually will wean the ventilation aspect before the pressure aspect. So typically, most people would wean by blood gases. If the blood gas is fine, the FiO2 is low, we must be weaning this patient. But our approach is a little bit different because the respiratory system, which is the chest wall, the abdomen, the lung itself, is not on a table by itself. And a lot of times if you just look at blood gases, why do you even need to look at the patient? Just make your decision on a blood gas. Just call and say, what's the blood gas? Okay, go ahead and wean the patient. So where is that patient going? What's happening to their thoracic mechanics? So we have patients that go to the operating room every day, every other day. Those patients are bleeding, being resuscitated, bleeding. I can tell you their thoracic compliance is not going to improve, and more likely worsen. So why do I want to take the pressure away because the PO2 is good right now and shrink the lung, and then the lung becomes white, the lung becomes more likely to be injured, and now I can blame the patient for having lung injury. So in what we do typically is try to determine where the patient is in their time course. And just very quickly, this is in the presentation I'll have next, but patients, I believe, go through 3 distinct phases. There's the resuscitation phase, which is very, very important because this is when you're likely to cause a lot of lung edema and potential lung injury, and of course, ascites. Patients that receive resuscitation are likely to develop ascites, especially if they're septic or trauma, and of course, that's going to affect their respiratory mechanics. And so, when you're in that phase, your airway pressure, regardless of blood gases, may need to go up. And that's what we would do, despite the PO2. At some point, the patient plateaus. You're not giving them fluid overnight, their vasoactives are not increasing, organ dysfunction may be a little more stable, everything is a straight line. And then the patient goes into a phase where we call it recovery, where we are changing their body back to before their injury, before their sepsis, because they don't look the same anymore. We can't expect their mechanics to be the same. So then we would try to remove the fluid we resuscitated them with. So I always like to tell the trainees, my fellows, that when you resuscitate a patient, you are only lending them fluid. They're not to keep it. So we want it back. And at that point, you're able to actually decrease pressure. Now, short of that, you can increase the time as much as you like, and the patient is still weaning. In other words, weaning requires the patient be independent in their ventilation and their lung not to require any pressure. Pressure independent lung. Take the tube out, the lung doesn't collapse, and the patient is still able to breathe. It doesn't mean you can only reduce pressure. So we wean the patient. Sometimes we're on CPAP without ever touching the initial APRP pressure. In fact, before I came here, my patient was on a CPAP of 26 because he was going to the operating for 10 days. He was going to the operating every other day. Every other day he was going to the OR. 2 to 4 liters of blood loss every day. Extremely bad leg that eventually had to be amputated up at the hip. Pelvic fracture. So lots of bleeding, lots of resuscitation, lots of inflammatory response where you have permeability. So in short, we're trying to harmonize what we do with the ventilator to where the patient is. Because just restoring blood gases does not mean their lung mechanics have normalized again. I hope that answered the question.
I just wonder, what kind of ventilation do you use during the OR in the patients that you bringing back and forth, and you're using APRV in the ICU?
Yes, so we continue using APRV. So we very early on learned that if you try to convert them to conventional ventilation, that your patient may not even go through the operation. They'll de-recruit, desaturate, and so on. So we unfortunately, it does take away the option for inhalational anesthetics, but we will take the ventilator down to the operating room and use intravenous anesthesia. And of course, we are hopefully going to be, we're very interested in the new device, the Perseus. Yes, Perseus, a demigod instead of a god. You were Zeus before, but now there's, okay. So Perseus has APRV in the anesthesia machine. And from what I've seen, it would be, for us, quite useful because the majority of our patients are actually undergoing operation on the ventilator on APRV. Other questions? Hello?
Yeah. Is it working now? Yeah, okay. Hello, I'm Jacob. I have a question. Do you see any problem in using APRV as the primary standard ventilator setting?
Not since 1996. So we have been using it as soon as the patient has been intubated, or even non-invasively since then as a primary mode. And in the afternoon, I'm going to present some data to suggest that what we believe is that if you do this, you can prevent the lung from being injured and ARDS. So most of our work has moved towards prevention. And just to give you a little bit of background here, in the 1990s, I started ECMO, an ECMO program in our trauma center. And the technology was not as good as it is today. It was much more cumbersome and riskier, and oxygenators leaked and all kinds of problems like that. So it was not very popular. And that's when we started using APRV. We started using APRV purely rescue, purely as very, very sick patients. And what we found was 80% of our patients referred to us for ECMO were on 40% oxygen and sitting in a chair the next morning. And I'm not joking. This is, of course, we didn't say, oh, we've discovered the cure for ARDS. What we understood was a lot of patients have atelectatic lung disease that we mistaken for ARDS. And of course, if you leave the lung half collapsed, half inflated, you may actually injure it more with stress concentrators, stress risers at the interface between collapsed lung and healthy lung. So we just realized that this is a good way to recruit the lung and make the lung normal. I can show you x-rays that go from completely white to completely normal. I can show you PF ratios that are under 70 and they go to 450 in 12 hours. That's not ARDS. I mean, I've been, trying to understand ARDS, the syndrome, for a long time. I still don't understand it, to be quite honest, but I know it's not just collapse that just disappears like this. But if something is a mimicker, then at least move those patients so we don't even have to study them. Because I think we even study those patients in the data that we look at. And they're, in my view, completely different. They survive, they have a good outcome. But we just have to recognize who's who. Because I think if you leave that patient, put them on ECMO, do things to them, rest their lung, whatever that means, because I don't know what lung rest means, other than it sounds nice. It's just, or lung protection sounds good too, but I'm not sure I understand that fully. But I think you will hurt those patients. So we use it purely as rescue, and then we started simply using it sooner. So this patient's probably going to get sick. Let's go ahead and start them on APRV. We were using pressure control up to that point. And then one day it was, hey, why not put them on as soon as they come in? And eventually we created, for us, a standard care mode around 1996. So since then, And this is why, in my view, of course, we have the world's largest experience, because everybody, we're not using it just for here and there, we're using it on everybody. Medical and surgical and trauma patients.
I have another question. If you use APRB as the primary setting, or maybe it's a question to Penny, how do you set your P high, pressure high? Because you showed us if you convert it from other modes.
I think I know what she's going to say, so since I have the microphone, I can. So going back to the rescue situation, the airway pressure is much higher. I'll just tell you, you would be in the 30 to 45 range, CPAP, P high, rescue. If you use it what we call preemptively, you're going to be in the 20, rarely 30 centimeter pressure. So most of the, this is adults, most of the pressure is going to be somewhere in 20, mid-20s range, and you don't need to do much more. The patient that I was just describing to you before I came here, who we extubated right before I came, because despite going to the operating room and losing 2 to 4 liters of blood every operation, every other day, and sepsis from a leg we were trying to save. He had a very destroyed leg that we thought we could save the leg until he started having gram-negatives in his blood and lost his blood pressure and everything, and received massive transfusion because he also had a vascular injury to the leg. So he was received, I can recall how many units of blood and FFP, everything you can imagine that would make his lungs injured. And he was on maximum pressure, he was at 28 centimeters of water. And he was big from resuscitation. So that was the pressure we were using. And the whole time he was breathing, except when he would go to the operating theater and come back. And his lungs on x-ray were perfectly normal, and his FiO2 was 25% the whole time. Completely clear x-ray. And then our goal was to not add another problem to his list. We felt that his list was fairly extensive. So if you have lung problems and all of these other problems, you become a very, very sick, unstable patient. So our idea is not to just leave the lungs away from the problems. And if you do that, we find that these patients extubate very, very rapidly because their lung volume is healthy the whole time. So that's our goal in essence of why we use it as soon as the patient's intubated.
And just to add to that, one thing, the slide that I had, the recruited lung takes less pressure than the recruiting lung. So what we saw over the years was that when we first started using it as a rescue mode, the pressures were much higher. They were in the 30s, they were in the 40s, because we were rescuing from a completely collapsed lung. Versus now, if you apply it early and preemptively, that the pressures are in the 20s, maybe 30 range.